Oh, are you here, Howard?
Yep.
Oh, welcome. All right. So this is a 40-something-year-old who has very angry, bad lungs, and you can see the left upper lobe is all cavitated out, and there's all this scarring and cavitation in the right lung. And you can see there's some traction bronchiectasis, volume loss, pleural thickening. And this is a patient who has a history of tuberculosis that was treated. And the question, and then they were presenting with some new symptoms. And so the important finding in this case is the presence of new small airway nodules out away from other areas of abnormality. You see some air trapping, but that's about it. And so the point of this case is it's difficult on imaging to determine if there's active tuberculosis, but one finding that has been shown to be suggestive of it is the presence of tree and bud or central lobular nodules in the lungs, particularly if they're a little bit away from other things, because it suggests there's mycobacteria spreading. This is probably some hemorrhage or something related to all the infection. Um, but ultimately, it really becomes, of course, a sputum diagnosis. But you can see really bad TB in the lungs here, pretty typical of that chronic cavity. You could spill stuff out of the cavity into the airways, but this cavity is pretty dry looking. There's not a lot of fluid in there, so uh, this all these little tree and bud clusters correlate with active TB. The next case is a 29-year-old who also has tuberculosis. And you can see there's a thin-walled cavity in the right apex, and it's associated with bronchiectasis and volume loss, but then has the same finding here. You see these little clusters of central lobular nodules sort of away from it, little tree and bud out there. And this is also, and then there's even some on the other side. So this is another case of sputum positive tuberculosis in a patient with previous disease. So I learned in training, and a lot of the older textbooks talk about reactivation tuberculosis, but in reality, last time I read, about half of these cases are actually new infections, and that's because we have PCR and a bunch of genetic testing they can do on the organisms, and that's shown that it's different strains of TB, and that's particularly true in endemic areas. Even so, it does not treated TB or previous TB does not confer any permanent immunity. Now, this case is interesting, and let me get these in the right order here. All right, so this is a middle-aged person whose occupation is a school teacher and has chronic lung disease and has a pleural plaque. So there's been some asbestos exposure, but you can see these calcified nodules. And then there's these chunky calcified and mediastinal and hilar lymph nodes. And you can see all of these perilymphatic nodules in both upper lobes predominantly, but all throughout. And I wondered if this was going to be silicosis, given that there was a pleural plaque. I wondered if the patient worked in a foundry or had some other sort of occupational exposures, but turns out no. I don't know where the asbestos exposure came from, but it's there. Um, but this is all sarcoid, and the patient had had a biopsy years ago that showed the non-caseating granulomata and no occupational exposure, so this fits just fine with sarcoidosis, and there's some conglomeration. Now, if we jump ahead to the more recent scan, um, we'll notice there's now, actually I should go back one more than that. Let's go back this one. Yeah, so back in about a year or so, or couple years later, the patient developed pleural effusion, which is not a typical finding of sarcoid. And you can see the lungs kind of adherent there. There's probably some visceral pleural thickening. You can see a little bit of parietal pleural thickening, and just had this effusion. I'm not sure what was done with it at the time. I believe it was sampled, but there weren't any real good records of that. But not much came of it. And then the patient came back, and at this point has a fusion now on the other side. The left effusion is much smaller, but now has this really thick rim or rind of pleural thickening. So it has these new effusion on the right, smaller effusion on the left, but clearly it's thickened. So acting like, and you see hypertrophy here of the extrapleural fat, so some chronic inflammation. So you always think about malignancy with a new effusion. You can also think about a chronic infection. You can think about autoimmune disease. Of course, sarcoid is immune related, but the patient didn't have any other autoimmune disease. And the sarcoid itself, there was a little bit more conglomeration of these nodules up there. And I think at the outside hospital, this was concerning for a mass or something, but we just told them it was, if you look at it, it's actually got a lot of calcium in it. So that's just all part of the sarcoid. But what's interesting is they sampled this pleural fluid and actually identified tuberculosis. It was lymphocytic, and I believe there was sputum positivity, but it was pretty weak because there was nothing in the lungs, even going back and looking, that it all suggested this patient had pulmonary tuberculosis. I didn't see any tree and bud, any new consolidation. These were all the same perilymphatic nodules. So I'm presuming, I can't prove it, but my presumption is this is pleural TB back in 2022 or wherever this at this time, and it sort of is like became a pleural a tuberculous empyema that was sort of contained on its own, but the patient still has viable organisms, and somehow it's seeded the other side and is growing in the airway somewhere. So this is a case of tuberculosis in someone with really no risk factors other than structural lung disease.
So Jeff,
Yes,
do you think that the lung calcifications are just part of the sarcoid?
I do, because they pre-existed the pleural disease, and yeah, I mean, if you look at them, they're all perilymphatic. Let me see, get a bone window here, and you can
Right.
see, yeah, I think it's all just sarcoid. It's not that common for sarcoid nodules to calcify, but they do. That's why I was wondering if this was silicosis, but it
Right.
was
And
not.
then the other thing, do you think that's really a pleural plaque or do you think that's a pseudo plaque?
I think it's a
Um,
real plaque. Let me show you.
okay.
I mean, if you
So
look at that,
pseudo, yeah,
it's got
that's
the mesa edge. It's got true calcium. It's not like little clustered nodules. That is a real plaque.
okay, good. So, school teachers are exposed to asbestos in the ceiling tiles. Those buildings, most of the old
Right,
school buildings have asbestos in them.
right,
So it could have been that. Could also have been some remodeling project at home,
right.
you know.
Yeah,
Um,
speaking of pseudoplaques, you sort of get some, they're not the best examples, but this you get when you get conglomeration of these subpleural nodules like this, they form the pseudoplaques. All right, and then this last case is just an example. This is another case of tuberculosis, and this is a patient who has chronic pleural TB, received treatment, and you can see there's this just thick rind of pleural tissue, and there's this dense calcification in it. Really, it's all pretty dense material there. So had been treated for it, and so this is sort of like a tuberculous empyema, and they can actually harbor organisms, but at this point it's contained. There was no pulmonary TB, and typically that you don't want to poke around at these things unless the patient's having symptoms, fever, weight loss, things like that. But pleural empyema, TB empyemas don't always go away, especially if it's sort of like the previous case I showed you that kind of ran on its own. But this one is more florid, and this is probably all just scar tissue in here, but again, can contain viable organisms. If you saw new cavitation or gas in here, you'd have to worry about it. But not too many things give you this dense of a rind that are other than tumor. And even just people have had empyemas from staph or something, they usually get pleural thickening afterwards, but I've never seen this degree of exuberant calcification aside from a big hemothorax or TB empyema. So just a little spectrum of TB, the more typical things, but also unusual things. So new pleural effusions in somebody in the right, it can always be considered, especially if they're lymphocytic. And I think, if I remember, they have low glucose, that's suggestive, and it may not be in the sputum. And now they can do PCR on the pleural fluid and easily identify it. And then if you see anybody with sort of looks like a chronic empyema, that's usually TB in most parts of the world. All right. Stop sharing and go back. All right, who's ready?
I can go, Jeff.
All right.
Do you see my database okay?
Yes, we do.
Okay, and now when I go to the 2D window, see that?
Yes.
Good. Okay, so this is just a fun anatomy case, if you will. So I'll give everyone a moment to look at that image. And the findings, of course, are subtle. Let's see if you see anything potentially
Oh,
interesting.
the left hilum looks off. I don't see the
Aorta,
hypervolemia well.
just above the arch.
The aorta, is something wrong here? Maybe.
There's a
Looks like
lucency.
it's
Yeah, I don't know if it's a mock line
too
or
busy
something.
right there. Yeah.
Too busy. Okay. Jeff, keep on the thought of the left hilar region. What is it about it that
Well, I don't
looks?
see the left pulmonary artery coming out and branching. And it looks like the left lung is I don't know if there's no rotation. It's a little more lucent in that upper portion
Yeah.
there. I think that goes along
I
with what
wonder if,
Travis is pointing out too.
yeah, could there be some volume loss and just elevation of that left hilum distorting the
Hmm.
pulmonary artery?
Okay. Excellent. So now I'm going to put alongside an exam from 2008 and check that out, that comparison. And while you look at that, pay attention to this little guy, which is the azygos fissure and the azygos vein. And look at the vessels, look at the location of it now compared to the way it used to look. Look at the hilar compared to the way they used to look and where they're located. So I hope I'm going to just mag this up because it's kind of fun case in that sense. So yes, both hilar are elevated, particularly the left. And these vessels here, I hope you can see that they're sort of curled in a little bit. The azygos fissure and vein, which used to be there, is now here. So we have some vascular findings, hilar findings, and we can infer that something is wrong with the lung. It's reduced in volume, so the fissure has gone medially. So that's kind of cute because this patient has, so I'll put this over there, history of lymphoma and mantral radiation therapy. So we have radiation fibrosis, and let me just try to find the image that shows the scarring in the upper lobes, the paramediastinal scarring. So it's kind of a fun case to show subtle findings, pretty typical of a sequel of remote mediastinal radiation therapy for lymphoma in this case. So kind of a cute case in that sense. Okay, here is a patient with, subtle finding. Anyone want to describe the subtle finding? Real subtle. I'll try to bring it out a little bit.
Not so subtle.
Actually, not so subtle, but there's actually a couple of findings, but there's
Yeah,
one that,
there's a
A
bunch
bunch
of
of small little
nodules,
nodules.
and there's
yep,
that
they have
mass in the
nodules.
apex.
Yeah.
Yeah, if I did something like that, you wouldn't see it. So there are nodules, and then there's a dominant thing right there. Yes. So here's the lateral. And if you look for that and see where is it, you look up here, you can't really pick it out. Now, of course, for this opacity, we don't see an interface, sharp interface between it and adjacent lung to suggest that it is in the lung. And perhaps one can say, well, maybe there are vessels kind of behind it that are not effaced by it. So now we have a chest wall lesion with nodules. And no surprise that we have this lesion right there that explains why it looks the way it does and its relationship with the first rib and the costal cartilage. And yeah, this is the way this patient presented with metastatic chondrosarcoma, like that. Yep. So nice teaching findings for an opacity like that for a non-pulmonary lesion, suggestive of a chest wall lesion. Okay, this one is, I'll skip that one for a moment. Okay, so this one is like this. So I don't know about your hospital, but when the cardiac folks here put in pacemaker devices, some of them, but not all of them, take some spot images during the procedure, and they record some so that they're available to review in packs. This is one. So this is one intra-procedural image. And then typically the one that everyone gets is the post image. So this is very soon thereafter. And then the patient is kept overnight, radiography the next day, planned discharge. So when we look at the leads, atrium, ventricle, atrium, and they're really hard to see that ventricular lead, which is kind of cut off. And then this is the next day, so I'll put the frontal here and the lateral there. And if you're not used to looking at these, you can go by these. So in paying attention to, because most people correctly look for a pneumothorax first, which is fine. But if you're not paying attention or read too quickly, perhaps you'll go right by the fact that this atrial lead is dislodged. And obviously on the lateral projection in particular, you can see it just hanging down. So you have to call them up and say, of course, don't discharge. Patient needs to have that fixed. So I tell my residents, when you see that, call up right away just in case they've missed it, which usually they haven't. Okay. This patient came to our hospital from another institution with, and the history we got was hemoptysis. So this is a CT for hemoptysis. And you can see the timing is such that the pulmonary arteries are nicely opacified. And quickly to go to here, you can see right away where the blood is coming from. These opacities, consolidation, left lower lobe. So, and this is a Watchman device, which is a prior event. And then we saw, resident correctly saw this and said, hey, wait a minute, there's something really wrong here. So let me just fix that up a little bit. And let's connect that up with and follow that to pulmonary artery. So pulmonary artery, and I'll make that bigger. There you can see the branch of the pulmonary artery going right into that guy, and then this thing is part of it. And then there's some vessel going away from it. So here we have this rounded opacity containing some contrast medium in the region of pulmonary hemorrhage. So we had to get some history to find out whether at the outside hospital they had recently done some kind of intervention, which it turns out they had, which was a right heart cath. So we surmise that this is iatrogenic pseudoaneurysm or aneurysm from that procedure. And no surprise, patient went to IR. Here you can see the lesion right there, and they embolized that, so we should see coils and so on. So an iatrogenic pseudoaneurysm of the pulmonary artery, presumably from a guide wire or something. It wasn't clear to us exactly how that happened, but undoubtedly that's what happened. Okay, let's see. Okay. I'll put these side by side. So this patient had uneventful cardiac surgery. He has a valve. He has a left atrial appendage exclusion device. All the usual things we see post-op. And the time between these is some days. So at this point in time, anyone want to comment on an interesting finding that is new from the 31st? Tubes are out, of course, and so on.
Superior wires going the other way.
Yeah, isn't that interesting? I mean, we don't usually see that, so soon after surgery, but that's
Right.
exactly right. These seem to be aligned kind of okay, but this one's clearly off, and that's exactly it. So I'll put the CT here and scroll through that. Get the lung window, so check out where the wire is. Let me just go down here. So far, so good. But when you get up here, you can see what's happening. This wire is actually passing through now through the incision, and the two halves are separating a little bit. So we surmise that it may have been properly positioned, tore through, and now the wire is really just in the right half, and here's some VRTs showing where the wire is located and the separation. I don't know if that's actually a tear through right there, but anyhow, they decided to leave that alone. It's just one wire, and they're just going to observe that and see how things go over time. Perhaps nothing really will happen, and maybe the sternum won't
How
separate
soon
any further.
after surgery was that, Howard?
This was like 4/6 approximately. What? Let me get the timing again. That's 3:31, and this one is 4/6. So that's like
So
a week later.
a week. So
This image.
on the early end of what you would expect from mediastinitis and dehiscence, it's probably just like a sterile separation.
Yeah.
That's
So we
what
think
they think.
it just pulled through. Yeah, exactly. Let's just go back to the CT and look at the mediastinal windows under that region. Yeah, there's nothing else under there particularly to suggest more than just a tear through, I think. Like that. Okay, so that was kind of a acute case. Let's see, which is this one? Can't remember. Okay, so actually, I'll skip that one actually. Well, maybe I'll come to that. This is great for trainees, so I want to show two images here, and I'm going to put a comparison up here. So two radiographs, and let's see the timing of things. So this is from 2022. This is more recent. So I was talking about this one primarily was interesting compared to this one, what was going on back here. And this is a really nice teaching case for teaching the findings consistent with hypervolemia. So what is different about this image compared to this one? First off, the vascular pedicle is wider, so the SVC is more distended here, as is the azygos vein. The pulmonary vessels, I'll make that bigger, are more distended than here. And the distended vessels here are more than just arteries. There's also vein. And they're equally distended in the upper lung zones and the lower lung zones. So this is what Eric Milne described as the balanced distribution of pulmonary blood flow. And the cardiac chambers are even bigger back then compared to now. So this is a really nice example of hypervolemia in a renal failure patient. You can see there's a stent now more recently, but those findings, of course, are not present on the recent one, but I use this to teach residents about findings of hypervolemia, kind of old style analysis of radiographs. So I thought you might like that, particularly if you're a trainee. These are really nice findings of hypervolemia. No lung edema, but just hypervolemia. Okay, Jeff, those are mine.
All right, thanks, Howard. Welcome back.
If I can go.
Travis, are you ready?
I can go, but Seth said he's got some too if he wants to go.
I just have to do a cardiac real quick in a couple of minutes. Yeah, if you don't mind.
Sure, yeah, you sneaked in on me. There we go.
Okay. So real quick. Oh, it downloaded. Okay, so this is an interesting case of a young kid with Kabuki syndrome, which you get some weird facial anomalies and mental retardation, and also associated with coarc, which he does have, that's been repaired. What's interesting here are really, do I have a lung window? That's really not pretty looking. Are the parenchymal nodules. So he had these parenchymal nodules that were, I mean, it's hard to tell, kind of center on the airway, but really difficult to kind of give a distribution. They're low predominant, and they did an open lung biopsy, and it was mostly, it was all AFOP and lymphoid hyperplasia. So like areas of follicular bronchiolitis really, and acute and fibrinous organizing pneumonia, kind of an airway center pattern. So they thought that he may have CVID, which he did. And so he wound up having CVID. I'll show you the spleen in a second. But because I guess CVID can be associated with this. So he does have a massive spleen. Well, not massive, just big. Only partially imaged there, but on the abdominal studies, it's imaged. And then a couple years later, he developed, with another biopsy, he developed Glielid. So this is a guy with some weird disorder who had lymphoid hyperplasia, and that's how they gave a differential diagnosis of CVID with AFOP, presumably from infection, airway-centered AFOP from infection, and then eventually developed Glielid. So just kind of a weird case. This is a really cool case for a couple reasons. One, let's see. So here's a guy with big lymph nodes and pseudoplaques and a bunch of nodules that kind of hard to put in a specific distribution, really kind of randomish. I really couldn't say they're all perilymphatic. I would personally call these random. And these, again, symmetric mediastinal hyalulymphadenopathy and these pseudoplaques, I would have thought sarcoid, but this actually turned out to be silica. But
what's
then
going on with his airways?
Yeah. So that's the kicker. So then on top of the silica, he has this profound, weird thickening and calcification of, you can see very beautifully how strikingly just involving the cartilaginous portion of the trachea. The membranous portion is very conspicuously spared and actually goes in to involve the main stem bronchi, and quite thickened and irregular, but not really stenotic. So really differential is either, relapsing polychondritis, usually like to see a little more stenosis, usually not as nodular-ish like this. And what this is, which they confirmed on PATH, which was tracheobronchopathy osteochondroplastica. So this
they actually biopsied it.
Yeah.
That is the most exuberant case I've seen, because usually we just see these tiny little bumps, and
Yeah.
people talk about it all the time, but it's like,
Yeah. There's a case from like 10 years ago that I think it was Arlene's case that I
Yes.
still like carry around as like the torch,
Yeah.
of T-pop. This is going to replace that now that, especially since it's path confirmed. That's awesome.
I have one I have to share it from the archives when I had access to them. That was crazy. I'm like, I've never seen it was like this, but twice as thick, and it was so odd. But yeah, it's so just randomly tracheobronchopathy osteochondroplastica in a patient with silicosis. But have you seen pseudoplaques like this in silicosis before? Again, I haven't seen tons of silicosis. Okay, well there you go.
What do you know what the exposure was specifically?
It was more fabrication of material.
Okay.
It was like, I have to look at the exact history, but it was material fabrication rather than like a minor.
Makes you wonder if it was like finer particulates, because it's like more peripherally located.
It may be, and exactly right, because and it was, because I remember looking at the history, and it was stone fabrication. So I would imagine, you're doing finer work, and probably that's definitely possible.
So how old a guy?
He was in, I have to check the age. I think he was in his, I have to check the age. He was in his 50s or 60s. He wasn't super young or super old.
So when you say fabrication, was he?
I have to look.
I wasn't doing countertops or something like that.
I don't know. I have to say, I found an amazing resource. David Lynch has a list of cases that are just by MRN, and I've been looking through them slowly. And the history I saw was tracheobronchopathy osteochondroplastica with silicosis from fabrication. So I didn't look at the history, but I did look, and they did biopsy. When they did the lung biopsy to prove the silicosis, they did biopsy the trachea on the way down for the bronch biopsy. So, but I don't know anything else about like if he's, granite or anything like that, or marble. This is one of these cases that, you look at it and you're like, it's stream bud nodularity, which it is. And unfortunately, that's a lot of what we see here is stream bud stuff. But this is just a cool diagnosis of why the patient has stream bud nodularity. Usually it's often seen with effusions, which this patient doesn't have. This is a younger patient. Airway's a little big, but it's not really. Anyways, he has yellow nail syndrome. So yellow nail syndrome is one of these weird things where it's some sort of lymphatic abnormality. And somehow the lymphatic abnormality leads to, I don't know if it's the plugging of the airways due to some sort of impaired lymphatic drainage. I would have to do more research on it, but they often present with effusions, which would be consistent with lymphatic drainage abnormalities. I'm sure one of you guys knows more about it than I do. But the imaging, I saw the case, I was like, oh my God, it's gonna be amazing. And it just was kind of stream bud, which I guess is pretty common.
Yep, airway disease. They can get I think they can get florid bronchiectasis.
They can. Yes, they can. They get florid bronchiectasis and yeah. And they have these very characteristic yellow nails. Okay, that's what I got.
Awesome. Yeah, all I've seen with yellow nail syndrome is like, pleural fluid issues. All right. Let's see. We got Travis left.
I'm ready now.
All right.
All right. See a CT?
Yep.
Okay, so this is a case that a colleague shared with me the other day, 63-year-old. The acute pulmonary emboli that they have is not the diagnostic dilemma. And she called me. She was saying she was about to sign off the report after she had read it out, and she noticed just this big tangle of vessels in the mediastinum here, and was wondering what it will, if I made anything of it. And the short answer is yes. And I think this is a really, really cool smoke case, actually, because first time you're scrolling through, you just kind of blow off this as just maybe a little bit of streak, maybe a little bit of heterogeneous flow in that right pulmonary artery. But we'll come back to this in a moment. And this hasn't been confirmed yet, but I'm pretty convinced that that circumflex artery looks a little generous here. And this whole tangle of vessels, just like tracing bowel in the setting of a small bowel obstruction, it all winds around into this mess of vessels here and ends up draining into that right PA right there. So this is the biggest portion right here. And I think we're getting smoke from a coronary to pulmonary artery fistula right there. Do you guys buy that?
Oh,
100%.
yeah.
Absolutely.
Yeah.
That's
So
a great pickup. Yeah.
I think this is the farthest out I've seen a PA fistula. Certainly, we've seen them to the main PAs, and you can see them to the SVC in every chamber. But yeah, so I just think there was debate about whether they should do a coronary CT. I think they should just go straight to cath. I don't, especially if they're planning on treating it.
Yeah.
You know,
So I had one from many years ago that was this distal. It was more conspicuous. It was associated with big aneurysm, and they went from the PA side and just coiled it from the PA side and interventionally, and that's all they did.
yeah,
But that's a very nice pickup. That would have been missed by.
yeah. It's right there on the sagittal. You can
Yeah.
see
Oh
it
yeah,
coming
yeah.
in.
Look at that. Spurting right
Yeah,
in. That's gorgeous.
yeah.
Yeah.
So nice little dark smoke case from inflow into the pulmonary artery, and in a patient with acute PE. So I kind
Yeah.
of
Gee.
now this is a case I've never seen before, and I'm curious if anyone else has, because I think we may have to write this one up, because this is a patient that for whatever reason got this CT it last summer, and as you can see, they have this, what I would call an area of consolidation or mass-like consolidation, and you see some dilated airways in it, and some mucus-impacted airways. There's no obstructing endobronchial lesion centrally. But of course, like this wasn't read in our division, and so one thing leads to another, and it's this has got to be cancer, yada yada yada. They bronch the patient, biopsy these nodes. There's nothing, and there's one thing here that because I was reading a follow up, and I went and I'll show you the other studies. But when looking at the airway, I noticed this funky little thing when I was reviewing this with my fellow. Uh, and you can see it's kind of a curious bronchus right there. I don't know what that is. This is the study that we read. Let me just show you the follow-up, and then I'll go back to what I think cinches the diagnosis. But you can see this area of consolidation has improved. So this was just a focus of infection. And you can still see that little thing right there. And I was able to dig up an old study in 2019. And what that thing is actually a bronchus supplying that area of lung. And on this study, you could actually see it was open. And then there's a little bit of plugging more distally in that.
Oh, geez.
And then it supplies the portion of the apical posterior left upper lobe. And you can see that there's still, I guess this is mostly anterior, maybe some posterior left upper lobe as well, or anterior and apical, and then this is just the posterior bronchus. But I think it was just compressed between the enlarged pulmonary artery and the aorta, which caused a post-obstructive pneumonia in this area.
Not seen that anomaly, but I don't know.
Yeah, well,
Probably hasn't
I've
been
seen that
described.
airway before, but I don't think
Have
I've
you?
ever seen it have a problem.
so
There's a
this is the Radiographics article, and I find these to be a little tough, but I think this image shows what this is the best. So it's a displaced left, and they're saying eparterial bronchus, because you still have some of the left upper lobe here, like in this case, but it's just coming off and passing between the pulmonary artery and the aorta. And I don't have the image, but the pulmonologist was able to pull up his bronch because I talked to him, and he did notice that there was a tiny little airway coming off posteriorly from the left mainstem bronchus. He didn't try to get into it. There was no pus coming out of it or anything, but I guess I would call this a left eparterial bronchus.
Sure.
I mean,
Sure.
yeah,
That's
Yeah.
cool.
When I've
Very
seen it,
cool.
there's often a funny fissure in the left upper lobe. I don't know if he had one. Not really.
Jeff, I have never noticed this bronchus
I've
before,
never seen it.
whether pathologic or incidental, but yeah, I just thought it was a
That's
perfect.
really cool, though. And I think there's an aborted tracheal bronchus too, right there. It looks like
Yeah.
there's a little like trying to come off on the right.
He had a right upper lobectomy.
Oh, this guy had a
Right,
right
right.
lobectomy. Yeah, he may have had a little tracheal bronchus nub, and I couldn't get the previous. Yeah, they
Okay,
had cancer in the right upper lobe, which is why they were getting followed and why they were worried about this. To
that's
start
really
with.
cool.
So is
Yeah.
it really
So I had
eparterial? It seems to me it's still hyparterial. Please show me how it's on the top of the artery. It seems to
I
be
always
well,
have
under,
to
under
draw
or
an old.
yes,
behind.
David, I think that's totally fair. I just don't. They're just calling it that, based on where it passes between. Like it's not. It's going above the pulmonary artery right here, but it kind of comes off proximal to the pulmonary artery and then goes above it.
Okay.
But yeah, I don't know. I would just call it a displaced upper lobe bronchus. Whether it does technically go above the pulmonary artery though, whereas everything else is going below it.
Mhm.
I don't know.
Got it. And
Yeah, that's
Yeah, I
really
mean,
interesting.
it's joining the regular left upper lobe. It's not a separate little mini lobe up there. At first, I
no, I
thought
don't think
in
so.
your first
Yeah,
imaging, I thought there was a pleural line, but I think that was actually just the skimming a vessel rather than a
yeah,
pleural
yeah.
envelope. Yeah.
So yeah, I think the rest of the anatomy in that left upper lobe, I think it's just a displaced segmental bronchus, whether it's apical or posterior, probably more likely posterior. And then it's like an anterior and apical right here. And then that's just going to this portion. So yeah, I have
Very
never
nice.
seen, there are a couple case reports, but never anything obstructed like that. All right. David, this one's for you. Uh, so I'll show you what I read. So again, we still get way too many daily ICU radiographs, and you know, the trainees love to hem and haw over whether there's a little bit of atelectasis down here or whatever. I don't care because the major thing is right here, which wasn't being addressed. And this patient had had 4 or 5 radiographs. and they'd had a spinal fusion instrumentation. And I went back and found a preoperative radiograph from a couple years ago because I was trying to figure out, is this an elevated hemidiaphragm? Is this some sort of subpulmonic collection? What do you guys think?
So hard on a portable film. I
Yeah.
mean, I would say
Yeah.
a collection below the diaphragm, but I don't know. I mean, that's a guess.
Yeah, I was thinking because so this is the immediate post-op radiograph. They had a pneumothorax. You can see most of the lung is collapsed. They ended up putting in a pigtail catheter. So I was thinking this had to be some sort of a pleural collection or subpleural collection that was just increasing. And especially their diaphragm wasn't elevated above, or prior to the surgery.
What's that
Now,
other
fortunately,
device to the left of the spine?
this is
That
this
other,
is a drain.
okay.
That's a superficial drain in their back. And so you can see they've extended the spinal fusion. Now, and I'm sure that your surgeons do this too, but they took an intraoperative CT. You can see the pneumothorax here, but I was just curious, what else we might be able to find. And you can see this is when they're just confirming that their pedicle screws are okay. But what they failed to notice was this. And so now I got a little bit nervous that this was a diaphragmatic injury.
Yeah.
And, could there be some sort of hernia or fluid collection? And
But
called the floor and
what's that chest
what's
wall
that?
defect? Isn't there a chest wall defect there as well? What's
Yeah, there
going on?
is. And I don't know if that's part of their spinal access. Because they've already stapled that. You're talking about this right here?
Yeah, there's a hole
Yeah.
there. Or seemingly.
Yeah,
Okay.
there is. I was more interested in the hole, what looked like a big hole in the diaphragm right here.
Yes. Yes.
And so called the floor. Patient had a little bit of pain, uh, but I told them, I think you need to get a CT and figure out what this is. And
Ugh,
it turned
that's
out
not good.
that that's all stomach.
Oh,
And
jeez.
that's all stomach, and it was incarcerated. And
Gastrothorax through it.
yeah, right. So it was an iatrogenic diaphragmatic hernia containing ischemic stomach that was
So
incarcerated.
Oh
could you
my
tell
God.
here? Could you tell here it was incarcerated, or that was a
No,
surgical thing?
they went to the OR a couple
Okay, because
hours
I'm
after
saying
this.
that'd be a really good call because I don't see any
Oh
gas
yeah,
in the
no,
wall or anything.
no. I mean, it was just that just it looked like they might be obstructed. Their esophagus was dilated, the stomach was dilated. They were
Yeah,
decompressed distally. Now, unfortunately, they only did the chest, but maybe I should have told them to do a full CAP. But the surgeons evaluated the patient. They were worried. They took her to the OR, and fortunately, that they didn't have to do a complete gastrectomy, but her stomach was ischemic.
ugh. And there
Yeah,
was a big hole
Do
in
you,
the
and it,
diaphragm.
so Travis,
yeah,
do you have a coronal that shows the
Yeah,
defect?
coronal and
It's
sagittal.
hard to find these things.
yeah. I know. I think,
Got a little bit of a collar sign
especially
there, I think.
right in here.
No, keep going.
Yeah, down there it
Go
seems
right,
to.
right there. Is that
Right there. Yeah.
somewhere there?
It's
Maybe.
let me just do an NPR so you can have a sagittal and a coronal because I think it's and I don't know. It's just so hard to tell.
It really is.
But
These things are really hard to figure out. It
I
seems to me that
struggle.
it's trying to form a waist down there where you get near the descending aorta contrast
right
there.
here,
Yeah, right
Medial,
there.
I think
medial
right
there.
Yeah.
that's yeah, and
I
yeah,
think
it's
it's
right.
trying
I
to,
think
yeah,
it's
the collar sign. Yeah.
yeah,
Yep, there's a defect there, probably.
and yeah, and
But,
unfortunately they did it more as an angiographic phase rather than I think they were thinking, oh well, let's just do a PE study rather than the venous phase might have helped show a little bit more definition of the pleura and the diaphragm.
and
But
that's pretty
yeah,
close to the operative level, right? I mean, they were right there, paraspinal, spinal.
yeah, yeah,
Yeah, yeah.
right. That's
Iatrogenic
lower.
diaphragm injury. Yeah,
Yeah, and Howard, I think to answer your
yeah.
question, I think that
Yes.
instead of going under the diaphragm, they went through the diaphragm to put this big interbody bone cage there, probably
Yep.
via this big defect laterally that you were talking about.
Okay. Gosh, yeah.
Yeah. And then there's some retroperitoneal air as well.
Wow.
So that was one of those, it was one of those ones that, especially because it was the fourth or fifth radiograph, but it was just didn't look right to me. So I went back digging.
Yeah, well done.
All right, and then I'll show, let's see, which one? This one. Um, I'll show this. So this is a patient who had an acute MI and went to the, no, it's this one. Went to the cath lab, and the cardiologist called one of my colleagues because they said, I think we have, I think they think they dissected the aorta. So you can see they placed a stent in the right coronary artery there. They may have done some work on the left side too. A couple of things that's interesting about this. You can see there's contrast in the aortic wall. So it looks like it's either an intramural hematoma or some sort of dissection flap that's just not opacified.
Yes.
One thing that's interesting about this is I don't even know why, but they sent us a virtual non-contrast because I think this was done on our photon counting scanner. But I think this actually highlights the pitfall of a virtual non-contrast because it's showing that there's less contrast there. But I was looking at this and I was talking to my colleague, that it's like, I think that contrast is too dense and it's probably from their cath. And then I realized they actually had a true non-contrast that they did. And sure enough, you can see that contrast is from the recent catheterization, not from the injection on the CT. So they had,
Yes.
and I know we've shown cases of this before with cath contrast being injected into the pericardium or into the aortic wall. I also thought this was kind of interesting. I think I thought it was on here. Actually, it's right there, Howard, right there. You can see there's a little bit of shared sheath contrast. It's getting into that shared adventitial sheath with the pulmonary artery.
Oh gosh, very
And
tiny speck right there.
I think it is. Yeah, because there's a little bit of wall thickening there and a little
Oh
bit of,
yeah.
but I think that's where that is
Oh,
rather than in the
intramural.
pericardium. What's
Intramural
that?
dissecting. Yeah, intramural
Yeah,
dissecting a little bit
yeah,
through the adventitia into the shared sheath. Very
yeah.
good. Yeah.
So, so the patient was fine. They were stable. And you can see there's no like discrete entry tear. We were a little worried about this right here along the right coronary artery, but they just repeated a CT the next day. They did not take them to the OR, and you'll see this is the one I originally showed that there's a little bit of intramural hematoma, but there's no frank dissection. That contrast, of course, is resorbed, so they're just going to continue to watch, and hopefully this will
Sure.
resolve on its
Should
own.
should be fine.
But I
Yeah.
thought this was interesting because it's kind of the pitfalls of a virtual non-contrast and also an iatrogenic complication we occasionally see.
So when did you get your photon counting scanner installed? Recently, or has it been?
No, we've had it since we were one of the first three. So
Were you?
yeah, it's been a year or so.
Are you doing? We're having some issues with ours, to say the least. I'd be curious
We
to.
can yeah, we've
Yeah,
had to do a lot of work tailoring the
yeah. We're having. Yeah,
yeah.
I'm glad you have one because I need to pick your brain because we're
Yeah.
struggling.
I personally think it's a glorified flash scanner for what we do. I know the neuro folks do some dural venous fistula and CSF spinal leak stuff that they really need the extra, the ultra high
It's just getting
resolution.
a lot of weird artifacts. We're doing some of this stuff at 0.2. It's pretty cool
Yeah.
for some things, but it's not really changing.
Yeah,
Anyways,
it's not
yeah.
changing your diagnosis of UIP, is it?
No, it's just saying like,
It
oh,
just
you can see that
yeah,
cooler.
yeah. It just looks prettier.
Yeah.
Yeah. Um, Jeff, I'm going to stop there. I got
All
to
right.
get to a conference here at 4.
Sure. Thanks, everybody.